All right. Well, thank you all for joining us today. The topic for today is sexual health following stem cell transplant. And it's my pleasure to introduce my colleague, Dr. Becky Hunter, who's an assistant professor in our program and works clinically with bone marrow transplant and blood and marrow cancer folks. She has a doctorate from the University of Kansas and did her residency at the Palo Alto VA. During her fellowship year at Loyola, she worked to implement a couples-based sexual health intervention for cancer patients and also wrote her dissertation on a sexual health topic. Most recently, she's collaborated with both the Late Effects and Quality of Life Working Group of the Center for International Blood and Marrow Research, and also the Transplant Complications Working Party of the European Society of Blood and Marrow Transplant, on a new systematic review recently published on male-specific sexual impacts of stem cell transplant. So all that to say, she's an expert in the field of sexual health in the context of bone marrow transplant, and she's going to present to you on this topic today. Again, it's my pleasure to introduce Dr. Becky Hunter.
Thanks so much, Ben. Okay, so I just want to make sure, can everyone hear me okay? I'm assuming yes. Okay.
Yes.
Okay, great. I don't have anything to disclose. And before we jump in to this topic, let me move this other window over here. Okay, good. Before I jump in into my presentation, I really want to comment on a few things that's important to keep in mind as I'm talking about this. First, in regards to research in sexual health, not only in oncology population, but also specifically with stem cell transplant patients, is that there truly is a dearth of literature. There just isn't a lot of research done on this area. And any research that has been done, in the context of cancer, oftentimes it's done in a breast cancer population. But overall, most of the participants in these studies are heterosexual, they're cisgender, and they're white. And then related to that, patients and couples participating in these studies about sexuality generally have higher SES and are of middle or upper middle class backgrounds. So this is obviously problematic for a lot of obvious reasons, especially due to the well-documented health disparities that we already know exist for patients of color and for patients who might identify as LGBTQ+. So as I am talking about all of this today, please keep this in mind and think about some of the recommendations and the treatment approaches we can take, that we can take with patients. Think about how you can tailor them specifically depending upon a patient's cultural, religious background, sexual orientation, sexual identity. Okay. So let's start with the basics. What is sexual health? Sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. And there's a lot of components and examples of what sexual health is. So for example, it includes how we feel about our body or our body image, sexual experiences, thoughts, ideas, and fantasies, how we experience intimacy and touch and love and compassion. And it also includes things like gender identity and sexual orientation. And it encompasses, it's sort of an umbrella term for sexual well-being, sexual distress, and sexual dysfunction. So not only is sexual function impacted by a number of domains, as you can see in this graphic, but common symptoms after stem cell transplant also have both physiological and psychological components. Consequently, separation of these factors is somewhat artificial. So this figure contains a conceptual model of sexual dysfunction that includes physiological and psychological components. Fatigue, depression, insomnia, body changes, even pain or other physical issues may have biological roots, but they also have cognitive and emotional consequences that can actively contribute to inhibiting sexual activity or responsiveness. So if a person barely has the energy to maintain mandatory daily activities to promote health, it can be hard to imagine saving time and energy for sex. So for survivors of transplant, this is a common experience in the months after therapy. In addition, appearance changes in hair loss and muscle loss and skin rashes, skin sensitivity or dryness, scars, weight changes, all of these things influence body image, which in turn contributes to the sense of self-consciousness. Fear of pain or discomfort, and even fear of failing to become aroused can become barriers to trying to have sex again for both survivors and their partners. Another barrier to return to sexual activity after transplant is the expectation that responsiveness should return to as it was before diagnosis. Lack of communication about what's changed, what feels good and what doesn't feel good, and then insecurities about appearance can often inhibit a couple's attempts at intercourse. And these worries and the lack of communicating concerns often also is then reflected in reduced intimacy, because emotional intimacy and physical expressions of closeness for many couples are seen as precursors to intercourse. So patterns set in the months after returning home from transplant can turn into habits that continue for many years. So something important to keep in mind. So now let's dive deeper into sexual health and focus specifically on sexual well-being, sexual distress, and sexual dysfunction. And remember, all of the factors that I just reviewed also impact these three concepts. So sexual well-being is a lack of pain, disease, or impairment in sexual functioning, as well as the ability to maintain sexually related physical, psychological, and social health. Sexual distress is, as you can imagine, the psychological and emotional strain resulting from disturbances in sexual functioning. So again, physiological, psychological, and social factors interact to impact sexual well-being and sexual distress. So for example, for transplant survivors, many side effects of the transplant itself, such as the systemic manifestations of graft versus host disease to the skin or to the GI tract even, for example, can indirectly impact sexual well-being, independent of structural changes to the genitals. Similarly, infertility associated with transplant can contribute to a decline in sexual well-being by exacerbating distress and anxiety, thereby affecting intimacy, relationships, and sexual health. Now, in terms of the prevalence of this in transplant patients, nearly 50% of men and 33% of women post-stem cell transplant experience increased sexual distress. And in allotransplant patients in particular, 32% of patients reported dissatisfaction with sex appeal and 17% report dissatisfaction with body image. Other factors that impact sexual well-being and sexual distress. A lot of times, of course, as we know, transplant survivors experience more anxiety, depression, self-esteem concerns, and perceptions of stress, all of which can indirectly compromise sexual well-being. And this is problematic because we know that mental health concerns are pretty common in this patient population. So for example, 20 to 55% of patients report anxiety and or depressive symptoms, and 26% actually meet criteria for major depressive disorder. 30 to 40% of patients report an ongoing fear of recurrence. And importantly, this is something that's important for all providers to know working with this patient population, is that some studies show upwards of 80% of transplant patients experiencing subclinical PTSD symptoms. And in fact, around 5 to 19% of transplant patients actually experience clinical PTSD, and that's in comparison to 14% of non-transplant patients. And then finally, as I'm sure we all know, 38 to 61% of transplant patients report sleep disturbance. So obviously, when you are experiencing any of these mental health concerns, then you're also likely to be experiencing greater issues with sexual well-being. So before we talk more specifically about sexual dysfunction, let's refresh ourselves about the models of the sexual response cycle. So Masters and Johnson first described that we have 4 general stages in the sexual response cycle, which includes excitement. So in this model, excitement is synonymous with arousal. Arousal involves the mental or physical stimulation resulting in feelings of pleasure, and the physiological changes that include things like increased muscle tension, accelerated heart rate and breathing rate, increased blood flow to the genitals, vaginal lubrication begins, and then in men, the muscles at the base of the penis contract. This is followed by plateau, which is essentially the brink of orgasm, meaning that all the changes that started in the earlier phase of excitement are intensified. Next stage is orgasm, which is the peak of sexual pleasure when blood pressure, heart rate, and breathing rate are at their highest, and there's a rapid intake of oxygen. There's a sudden forceful release of sexual tension and ejaculation in men, and then the muscles of the vagina contract in women. And then finally, during resolution, the body slowly responds to its normal level of functioning. And this phase is generally marked by enhanced intimacy and fatigue. While women are capable of rapid return to the orgasm phase with further sexual stimulation, men need additional recovery time, which is called the refractory period. So you'll notice that one stage that was left out of this model was desire or libido, which is the drive to engage in sexual activities or fantasizing. And one thing to keep in mind with this model is that this is an overly simplified understanding of the sexual response cycle, especially when considering the sex-specific differences between men and women. So for example, we know that in a healthy population, 75% of males are able to achieve orgasm within 4 minutes after initiation of intercourse, whereas for women, the average time to reach orgasm is typically between 10 and 20 minutes. I lost my cursor. Oh, there we go. So an alternative model includes this model by Bassan, which incorporates motivation and reasons for engaging in sex. So in this model, there are phases that overlap, and there's some phases that occur in a different order. Also, as we can see, the spontaneous sex drive is a component of the sexual response cycle, but there are a number of other important contributors as well. So for example, people in relationships may engage in sex, not necessarily because of sexual desire, but because of a desire for intimacy with their partner. So understanding the complexities of the sexual response cycle can better inform how we think about sexual dysfunction and the factors at play within our specific patient population. Okay, so diving more into sexual dysfunction. Sexual dysfunction is an inability to engage in all phases of the human response cycle. So what I just outlined: arousal, plateau, orgasm, and resolution. Sexual dysfunction and fertility concerns are the most common sequelae of stem cell transplant. And sexual dysfunction is actually more common in transplant survivors than in those patients who receive chemo alone. In our stem cell transplant population, 26 to 83% of women and 6 to 46% of men endorse at least one sexual health challenge. 38% report decreases in sexual functioning, 36% report decreased ability to have sex, 31% report reduced pleasure from sex, and 28% report reduced interest in sex. In terms of looking at the differences between men and women, women typically report problems with libido, vaginal dryness, and painful intercourse. And men typically report problems with obtaining an erection and ejaculation and orgasm. These effects are long lasting. So effects in men can remain for even 2 to 3 years post-transplant. And the effects in women can persist for many years after. So for example, one study found that 80% of women reported 1 or more sexual problems 3 years post-transplant in comparison to 29% of men. So to demonstrate the pervasive and persistent nature of sexual dysfunction and differences across sex, investigators out of Fred Hutch surveyed stem cell transplant patients before and after treatment, in addition to their matched non-cancer controls who were the same gender, ethnicity, and within 5 years of age of the transplant survivors. So the outcomes illustrated here include 3 groups. There's the controls, the relapse-free survivors, RFS, and non-relapse-free survivors, all divided by sex. So the graph on the left shows the percent of males and females who were sexually active among relapse-free survivors from before transplant to 5 years after transplant. Rates are also graphed for the non-relapse-free survivor patients before transplant and controls at 5 years. So both males and females declined in rates of being sexually active from pre-transplant to 6 months. And on average, males improved compared with 6-month levels by 1 year, whereas females improved by 2 years, but both remained below their respective controls at 5 years. The graph on the right includes the sexual function means for male and female relapse-free survivors from before transplant to, again, 5 years after transplant. And the means are also graphed for the non-relapse-free survivors before transplant and controls at 5 years. And both males and females declined in average sexual function from pre-transplant to 6 months, and females did not improve from 6 months post-transplant levels by 5 years, and they remained below matched controls. Males, on the other hand, improved by 2 years, but remained below their respective controls at 5 years. So as you can see, while men tend to do better than women in regards to rates of sexual activity and overall sexual function, there are considerably more concerns in the transplant population than their matched controls. All right, so let's get into specific sexual function disorders, starting with sexual arousal disorder. So sexual arousal disorders occur in both men and women and are defined as a diminished or absent feeling of sexual interest or desire, absent sexual thoughts or fantasies, and a lack of responsive desire. And for women, there are 3 subgroups. There's genital sexual arousal dysfunction, subjective sexual arousal dysfunction, and then combined genital and subjective arousal dysfunction. So genital sexual arousal dysfunction is absent or impaired genital sexual arousal. So for example, lack of vaginal lubrication from any type of sexual stimulation. Of note, the subjective excitement still occurs from non-genital sexual stimuli. In contrast, subjective sexual arousal dysfunction is the absence of or markedly diminished feelings of sexual arousal, so sexual excitement and sexual pleasure from any type of sexual stimulation. However, vaginal lubrication or other signs of physical response still occurs. And then finally, the combined genital and subjective arousal dysfunction is the absence of markedly diminished feelings of sexual arousal from any type of sexual stimulation, as well as complaints of absent or impaired genital sexual arousal. In women, transplant patients or transplant survivors, 68% experience less enjoyment from sex after transplant, and 83% report a loss of desire. And there are a number of contributing factors, including vaginal dryness, which is very common, vaginal narrowing, which occurs in 34% of women, and then vaginal irritation. And this is in comparison to the general population, where this occurs between 17 to 55% of people endorsing low desire. Now, in men, the most common arousal disorder is erectile dysfunction, or ED, which is defined as consistent or recurrent inability to obtain and or maintain penile erection sufficient for sexual activity. And this occurs in anywhere between 61 to 75%, so a huge chunk of our population. 61 to 75% of male patients endorse ED after transplant. And it's been found that these problems can persist 1, 2, 3, 5, and even 10 years after transplant. This is in comparison to the general population, where in men under the age of 40, it occurs in about 1 to 10% of people, of men, and in the age range of 60 to 69 years old, it occurs in about 20 to 40% of that population. Orgasmic dysfunction is the inability to achieve orgasm, markedly diminished intensity of orgasmic sensations, or a marked delay of orgasm during any kind of sexual stimulation. In women, now, and again, the important thing to remember here is that there's some limited data. But of what we know, in women, about 23% of survivors experience failure to orgasm. And that's in comparison to the general population, where this is found in about 16 to 25% of women between the ages of 18 and 74. In men, about 38% of male survivors experience a delay or absence of orgasm. And this is in comparison to the general population, where it's typically found in 8 to 30% of men. However, the important thing to remember here is that those rates in the general population are descriptive of early or premature ejaculation rather than delayed or absence of ejaculation. All right, another sexual function disorder is dyspareunia, which is persistent or recurrent pain during sexual activity. And in women, this persistent or recurrent pain occurs with attempted or complete vaginal entry and or penile vaginal intercourse. And in women survivors, it occurs in between 30 to 73% of women who endorse experiencing painful intercourse. So maybe not necessarily to that clinical threshold, but they are endorsing painful intercourse. And that's in comparison to the general population of between 14 and 27% of women. In men, we know much less about this. It's unknown in male survivors what percent experience this, and that's in comparison to the general population, where we think it's around somewhere between, the prevalence is around somewhere between 3 and 6%. One important thing to keep in mind is that dyspareunia is likely a part of male sexual dysfunction following transplant, especially given the impact of GVHD, for example. However, it may be considered a component of ED rather than being specifically considered dyspareunia. So since we reviewed the different types of sexual dysfunction disorders, I wanted to highlight gender differences across some of these domains. So these are data from a group out of the City of Hope who described the trajectory of sexual well-being from before transplant to 3 years later in 131 allo patients and 146 auto patients. And as you can see, they specifically looked at total sexual function, sexual cognition and fantasy, orgasm, sexual arousal, and sexual drive and relationship. So this study found that 61% of men and 37% of women were sexually active pre-transplant. And then the prevalence declined to 51% in men and increased to 48% in women at 3 years post-transplant. After transplant, sexual satisfaction declined in both sexes. And as you can see in these graphs, all sexual function domains were worse in women compared to men. Orgasm and sexual drive declined in men, but interestingly, sexual cognition and fantasy and sexual behavior and experience improved in women. And as you might imagine, older age also negatively impacted sexual function post-transplant in both men and women. So while there are potentially a number of factors negatively impacting sexual well-being and sexual functioning following transplant, there's only evidence for a few as being impactful. And these risk factors can have either a direct or indirect effect on sexual functioning. So let's first start with a conditioning regimen. So for example, TBI. And there's evidence that the acute side effects of TBI, obviously including nausea, emesis, fatigue, all of those things, they can indirectly affect the desire for sexual activity, understandably so. There's also evidence that it's directly toxic to gonadal function. Additionally, with alkylating agents, it can impact fertility in both men and women, and then it can cause menopausal symptoms such as vaginal dryness and low sexual desire. Another treatment-related effect is chronic genital GVHD. This understandably can lead to impaired emotional well-being, sexual dissatisfaction, decreased arousal and orgasm. It leads to essentially genital manifestations that directly affect sexual function, with pain being the most significant effect of the changes. In women, chronic GVHD can include vaginal dryness, dyspareunia, amenorrhea, vulvar or vaginal scarring, vaginal stenosis, and loss of libido. And in men, chronic GVHD can include lichen planus-like or lichen sclerosis-like features, phimosis, urethral scarring, and stenosis resulting from genital skin inflammation. Another treatment-related effect includes cardiovascular disease. So the impact of cardiovascular disease in the general population has been associated with ED. However, there is limited data regarding ED in long-term transplant survivors with cardiac complications. However, we do know that certain medications used in cardiovascular disease, used to treat cardiovascular disease, such as beta blockers and diuretics, can cause sexual dissatisfaction and ED. However, there may not necessarily be a direct drug effect. And then finally, endocrine dysfunction is also related to sexual dysfunction. It includes hypothyroidism, which is associated with erectile and ejaculatory dysfunction, impaired libido in both men and women, and impairments in desire, arousal or lubrication, orgasm, satisfaction, and pain during intercourse. Diabetes is associated with ED in men and arousal disorder, and in women, orgasmic disorders and sexual pain disorders. Dyslipidemia is associated with ED in men, and there is limited evidence of its effect on female sexual dysfunction. And then finally, adrenal insufficiency is associated with ED, impaired orgasmic function, sexual desire, sexual satisfaction, and also an increase in depression and anxiety. And finally, medications can have an impact. So for example, so many of our patients are on SSRIs, and those can, of course, negatively impact libido and arousal and orgasm. Antipsychotics have also been found to contribute to vaginal dryness. And then other medications, including steroid immunosuppressants, proton pump inhibitors, opioids, hormone replacement therapy, antihypertensive drugs, and statins, can all contribute to sexual dysfunction for a number of reasons, including drug-drug interactions, pill burden, and then combined side effect profiles. Another obvious risk factor for sexual dysfunction is related to psychosocial distress. So as we know, the relationship between emotional and psychological health and sexual functioning is bidirectional. So depression contributes to decreased sexual desire. Anxiety contributes to concerns, for example, about desirability and performance. And then impaired sexual functioning at the individual or couples level may contribute to depression, about change dynamics or relationship quality, and anxiety, for example, about health or the future of the relationship. And there are some gender differences here. So in a study of survivors 1 year post-transplant, there was a correlation that existed between depressive symptoms and orgasm, sexual satisfaction, and overall sexual functioning in men. And anxiety in men was associated with orgasmic dysfunction and body image distress. Whereas in women, there was a correlation that existed between depressive symptoms and lower arousal, but there was no correlation found between anxiety and sexual function or body image outcomes. All right, so let's talk a little bit about body image. Body image distress is a unique type of distress that can contribute to sexual dysfunction. And there are multiple pathways linking body image and sexual function, including via hormonal and gonadal changes, which may in turn lead to a negative view of one's sexual self, or the change in physical appearance, potentially leading to sexual self-consciousness. Negative perceptions can be triggered by physical changes such as GVHD and the use of corticosteroids, which can cause weight gain and swelling. And then intensive protocols that cause greater physical side effects can, of course, increase the incidence of body image dissatisfaction. We know that young people in particular are vulnerable to body image concerns given increased focus on peer comparisons and the emphasis on physical appearance at certain life stages. And unfortunately, this can contribute to them postponing important relationship milestones that they otherwise value. And poor body image is associated, of course, with worse self-perceived general health and perceptions of the health of sexual relationships. Now, body image encompasses a lot of underlying factors that don't only focus on appearance and feeling sexually attractive. Rather, body image is also related to a person's ability to trust their body and to believe that their body has integrity. So in other words, it feels natural, healthy, and whole. So when a patient is struggling with infertility, or when they feel like their body can't physically carry them where they want to go, it feels like a betrayal. And when you feel like you can't trust your own body, then of course, it's not only going to affect your sexual well-being, but it's also going to impact your mood, quality of life, and your general self-efficacy. So body image affects how you see yourself as a person, what you believe about yourself, and what you feel like you can achieve. And it's a crucial part of a patient's recovery. So as a psychologist, I hear a lot of concerns about body image and sexual function. And it's because it hits on so many parts of a person's identity. It not only impacts how someone views themselves, but it also impacts the health and well-being of their relationships. So it helps the person feel like a partner rather than just feeling like a patient. It helps restore the equilibrium of their entire worldview. So to demonstrate just how impactful the effects are after transplant, a group out of Copenhagen completed a qualitative study to better understand patient experiences after transplant. And a few quotes I pulled from the study include the following. It was like I was also on sick leave from my sexuality. And in that very moment, you believed you were going to die because the air simply wasn't there. You wanted to finish even though you were fighting for breath because it's unfair to the other person to stop. So I thought if I pass out, then that is just what I'll do, because you push yourself to the limit and then you have to lie still for 10 to 15 minutes afterwards. I almost started to cry looking at old Christmas photos. It's one thing how you feel, and another is what you see in the mirror. You just look different. It's held me back from finding a partner. I feel it when I go out. No one looks at me. After all, you should have eye contact with people, but I can see that I look wrinkled and dark and fat. I haven't felt attractive. I also think about what my children say. When do we get our old mom back? And of course, they won't, because that isn't me anymore. I can't imagine that she, my partner, is turned on by me in the same way that she used to. It's a question I have never asked her, and I'm afraid of the answer. So we know that this is important, and we need to do something about it. So given the limited data available regarding sexual functioning within transplant populations, it can be difficult for practitioners to properly assess for, prevent, and treat sexual dysfunction, especially because to date, there is no single method deemed to be most effective in evaluating sexual dysfunction. Therefore, it's imperative to conduct a thorough sexual health-focused pre-transplant screening in order to establish a baseline to better track changes over the transplant course. We know that pre-transplant and 1 year post-transplant sexual function assessments are strong predictors of long-term sexual function for both men and women. And some considerations to have for pre-transplant baseline assessments. For women, you want to include menstrual management and evaluation of abnormal bleeding, fertility concerns if timing allows, and STI testing, including HPV testing. And then similarly for men, you want to include assessments and conversations, including fertility preservation, STI testing, and assessment of testosterone levels. And then post-transplant, routine assessments should include a focused genital assessments for chronic GVHD, and that should be documented and done with the guidance of the Vienna skin scoring of the 10 skin areas, or the NIH skin scoring of the 8 skin areas. You also want to continue with STI and HPV screenings. And after 100 days, menstrual history, ovarian function, and the use of HRT and contraception should also be evaluated in women. And primary ovarian insufficiency should be evaluated at regular intervals after transplant. And then once the patient has achieved long-term survival and is physically and emotionally motivated, fertility should also be discussed. So as we all know, there's a lot of challenges with screening before transplant, after transplant, et cetera. And unfortunately, sexual health concerns are oftentimes left unaddressed. And in fact, we found that upwards of 68% of healthcare providers do not address sexual function issues, and they typically wait until the patient introduces any relevant concerns. And I would argue, however, that that is too late. You know, I'm sure that we can all think about what it would be like to talk with our doctor about sexual function issues. It's uncomfortable, and oftentimes there's embarrassment surrounding the issues, especially for people who may not even know how to talk about it or have the right words to talk about it. So if we're waiting for the patient to say something, then these issues have likely been going on for a really long time and are probably quite impairing. What we typically see in folks who are less likely to address sexual dysfunction, we typically see this in younger or less experienced providers, in healthcare providers who aren't working in, or healthcare providers who are working in non-Western countries, providers with less sexual education and training, and with limited knowledge about the long-term sexual complications following transplant. And then, of course, just in general discomfort while discussing sexual issues. And, you know, what do people do when they're uncomfortable? They avoid the thing that makes them uncomfortable. So then it just doesn't end up getting addressed. And while there is limited research in this area, one study that surveyed healthcare providers found that there are really two main barriers to screening. One is the perception that patients would feel embarrassed if these subjects were discussed in the presence of a family member. And the other is that healthcare providers thought that patients would prefer the provider to wait until the patient initiates the discussion or raises the concern. But what the study also found is that there are things that helped facilitate these discussions. So having observed a team member successfully discuss sexual issues with a patient helps. For APPs and nurses, having a private space to discuss these issues is helpful, as is having SOPs on how to address sexual issues. And then for docs, what's been found to be helpful is being prompted by a care plan and having sufficient time to discuss these issues with patients, and also having knowledge of the sexual difficulties transplant patients experience. So these are opportunities for growth that we can likely consider in our own practice moving forward. Okay, so sometimes, you know, especially when you're implementing, you know, new domains of assessment, it's important to think about, you know, just what is helpful to get you to remember to ask about some of these concerns. And one study out of Canada provided sexual health training to oncologists working primarily with breast cancer patients. But I think their strategy is easily generalizable to our population as well. And they basically came up with this acronym CARD. And so they asked the providers the question, did you card him or did you card her? And basically what CARD stands for is C is cancer treatment can affect our sexual health, which is important to quality of life. A stands for ask. So do you have any questions or concerns about fertility or menopause, sexual health, vaginal dryness, pain, erectile function, or other sexual issues? R stands for resources or referrals. So if you're interested, I can connect you to, and then name the appropriate referral. And then D is for document, where you can say address sexual health concerns, resources given. So it's sort of an easy way for you to remember whether or not you discussed these types of sexual health issues. Okay, so given the physiological, the psychological, and the social factors that impact sexual well-being, sexual distress, and sexual dysfunction following stem cell transplant, treatment approaches should target each of these domains. A comprehensive approach to treatment includes consideration of a number of methods, including psychotherapeutic, pharmacologic, behavioral, and other treatment methods. So one of the things that can be helpful is referring patients to psychology, because we can address a lot of the contributing factors that are exacerbating a very real, very true biological issue. Some of the therapeutic approaches that we take, the first is through cognitive behavioral therapy. And basically what we do is we work with patients to identify how their emotions, beliefs, and behaviors surrounding their body image and their sexual dysfunction keep the dysfunction alive. And we find ways to target these maladaptive beliefs to keep the cycle going, but in a healthier, more adaptive way. We also can include integrative sex therapy. So unfortunately, there are limited interventions investigating types of sex therapy in this population, but one group out of Mass Gen created a multimodal sexual dysfunction intervention for survivors of allo transplant. And it's really cool. The intervention consisted of an assessment of the causes of the patient's sexual dysfunction, education and empowerment of the patient to address their sexual health concerns, and then lastly, the implementation of therapeutic interventions targeting each patient's specific sexual health needs. The therapeutic interventions included, but weren't limited to, gynecologic examinations to address causes of sexual dysfunction, and also included psychoeducation to address the psychological etiologies of sexual dysfunction. So for example, depression, anxiety, body image distress, things like that. Patients attended 2 to 6 monthly visits. And importantly, results from this pilot study showed improvements in interest in sex, orgasm, ED, vaginal lubrication, vaginal discomfort, quality of life, depression, anxiety, and an increase in sexual activity, which is awesome. Similarly, I actually helped facilitate a sexual wellness program for cancer patients when I was on fellowship that consisted of 5 weekly 2-hour sessions with couples hoping to improve their sex lives. Each session involved education during the first hour, and then a couples therapy session during the second hour. And in addition to having psychologists teaching the program, we also had urologists, gynecologists, and oncologists involved to provide exams that served to, 1, identify the physical contributors to sexual function, and then 2, to provide education to the patient and their loved one about how to navigate sex given the particular sexual dysfunction. And then finally, couples therapy is also incredibly helpful. And during couples therapy, we can focus on ways to enhance intimacy by using specific therapeutic techniques. We can expand the definition of what intimacy looks like and how it feels. So these are just kind of quick and dirty examples of some of the things that can be done just psychotherapeutically. Now, but let me check the time to make sure we're okay on time. Now, body image also deserves to be addressed as well. And when it comes to psychotherapeutic intervention, I do this in a few different ways. So one of the exercises that I do is something called Picture Yourself Happy. I ask patients to bring a photo to session, or it's just on their phones, that represented a time in their life when they were the happiest. And when asked to describe why the picture represents happiness, they often initially say it's because they're thin or they're fit or they're healthy looking. So in other words, the happiness was very much based on appearance. And then over time, I challenge patients to identify other qualities and characteristics that they value. So they start to describe themselves by using words such as empowered or confident or hilarious. And this exercise allows patients to recognize and connect with the qualities they truly value about themselves. And they can identify how many of these qualities have persisted despite cancer and despite treatment and transplant. Another exercise is, what can you appreciate about your body? So this is more of a mindfulness-based exercise that focuses on the function and not just the appearance of the body. So when I'm taking a patient through this exercise, I ask about whether there are any parts of themselves that they don't appreciate. They're asked to investigate what their body feels like and if there are aspects of their body that deserve more attention. And as we do this, I ask them to take notice of any emotions that might be coming up, both, labeled positive and negative. And if they're having a hard time identifying positive emotions, then we can create body positive coping statements associated with that. And then finally, mirror exposures. And if you know me, you know that I love treating a good anxiety disorder. So a lot of times patients who are experiencing body image distress essentially avoid looking at themselves. They avoid mirrors, they avoid looking at their own reflections in windows, basically anything that they can do to avoid looking at something that is dissatisfying and uncomfortable. Now, what we know about anxiety is that the more you avoid something, the bigger and scarier it becomes. So even though avoidance feels good in the moment, it keeps the anxiety alive. So with mirror exposures, we are leaning into the discomfort and using it in a productive way. So what I sometimes have patients do, and this is oftentimes during session, is I have them stand in front of a mirror for as long as it takes and reflect on 5 positive statements about their appearance and or what their body does for them. And then over time, rather than immediately focusing on the negative narratives that they've created in their minds about their appearance, they can more easily focus on the parts of their body that they enjoy or give them strength. Plus, the anxiety surrounding looking at their reflection slowly dissipates. Other treatment considerations include the pharmacologic interventions. And that includes topical therapy and systemic therapy. So for topical therapy, that's oftentimes primarily used in women with genital chronic GVHD, which typically manifests with genital dryness, inflammation, atrophy, and scarring, which can, of course, contribute to significant pain with sexual activity. And these can be alleviated to some extent, not completely, with topical steroids and topical cyclosporin, which helps reduce inflammation, and topical estrogen, which can also help with dryness and with the atrophy. Systemic therapy essentially involves use of medications to treat the underlying cause of the sexual dysfunction. So things like systemic hormonal therapy. And then it's also important to identify any cardiac and endocrine disorders that may induce sexual dysfunction and then treat them accordingly per guidelines. Other methods include mechanical therapy. So mechanical dysfunction can be caused by a decrease in sensation to the sex organs. And so mechanical therapies can help stimulate blood flow to the pelvic region. And this can be done through pelvic floor exercises, self-stimulation, vibrators, vacuum devices, and vaginal dilators. And I included a picture of what vaginal dilators look like. And then pelvic floor therapy conducted by trained physical therapists can also be incredibly helpful with this. There's also somatic therapy. So this can be used for the management of vaginal dryness, and that just includes things like vaginal lubricants and moisturizers. And then finally, sexual aids. And that includes erotic reading, sex toys, role play, fantasy. And it can be used for both individual and partner use, and it helps add novelty and kind of increase arousal. So in terms of some additional recommendations for providers to keep in mind, one thing to remember is the importance of managing polypharmacy and how that can impact sexual health and sexual function. There should be specific monitoring of genital symptoms, and that should continue with the tapering of medications. And then it's important to assess perceptions in changes of sexual activity or sexual function with any changes in medication. It's also, again, important to routinely assess sexual functioning along the transplant course. So in one study, approximately half, 50% of patients stated that there was no discussion related to sexuality with their provider before transplant or 1 and 3 years post-transplant. And in the same study, patients evaluated 3 years post-transplant who did discuss sexual health with their providers actually reported fewer difficulties with sexual functioning and sexual satisfaction. And discussion of sexual health prior to transplant allows patients time to process and prepare for changes. And it also allows for realistic expectations, and it helps facilitate open communication along the transplant course. And in general, assessments targeting sexual functioning and satisfaction post-transplant should take place at least every 6 months for the first year, and then annually. And something to just keep in mind with this is what's most important is just that you open the door for patients. It's uncomfortable for them, it's uncomfortable for you, but think about how you want to introduce talking about these issues to your patients. Oftentimes I say something like, you've been through a lot with chemo and now you're getting ready for transplant. It's pretty common for me to hear about changes in relationship dynamics, especially sexual activity or sexual functioning, for a whole host of reasons. Have you noticed any changes in those areas? And if the patient remains pretty anxious and has a hard time still, talking about this, you can give examples. So you can say, have you noticed that you just don't have desire anymore? Or maybe when you try to be intimate with your partner, you notice that things just don't quite work how they did before. Introducing these concerns gently can increase the likelihood that the patient will open up to you. And then finally, once you have a better understanding of these concerns, you can ask about whether these changes have been distressing and whether they're open to hearing about some treatment options. And then this can help you develop a plan moving forward, especially if the patient doesn't necessarily want to prioritize their sexual health in that moment. And then finally, providing educational materials can be really helpful so that the patients can kind of, think about this and learn about this at their leisure. So it's helpful to include information about moisturizers and lubricants, dilators, things like that. And then it's also important to utilize referrals to our specialist colleagues, including, urology, gynecology, et cetera. And then, of course, again, physical therapy for pelvic floor therapy, which is appropriate for both men and women. I've included some additional resources if you're interested in looking into this further. And I'm happy to answer any questions. Carrie, it looks like you have a question. Oh, shoot, I can't hear you. I can't hear you, Carrie.
Carrie, if you want, you can type your question. I think you did type your question.
Oh, there we go. Do you have any handouts that I can give to patients? Yes, I have some handouts. I'm a slow typer. That's okay. I have some handouts that I have saved, and so I can go through and I can share them with you, especially within the survivorship clinic. I think that would be really helpful. And then Jenny, do you find that insurance covers medical related costs associated with sexual health? That is a great question, Jenny, and I'm not totally sure. I think it just kind of depends on what it is. I know that certainly for psychology visits, it's, covered as much as any other normal visit would be with us. I know that for physical therapy, that generally those visits are covered for pelvic floor therapy. So without having a lot of detailed knowledge about that, I think that generally speaking, insurance does cover those types of interventions and referrals. Handouts. Okay, great. Yeah, maybe what I can do is I wonder what would be easiest for distribution of some of this stuff. Maybe I can reach out to Rachel to see if we can send handouts to people who were in attendance today.
Absolutely, we can definitely do that. I'll be sending a follow-up email, and I can attach the handouts, and we can do it that way.
Great, that sounds good. Give me a minute to kind of collect things, and then I can send that information to Rachel. Fertility guideline, yes, good. Yes, very uncomfortable. Yeah. I know it's again, it's just kind of like I said, it's one of those topics that everyone's a little uncomfortable talking about. But I've found that when I do ask the questions and when I bring it up, it's sort of like at first there's a little bit of discomfort talking about it, but then it's sort of like they just melt with relief because they're finally able to talk about it. They don't feel crazy. They feel like it's been normalized and they're not the only ones that are struggling with those issues. So it can be therapeutic in so many ways to just be able to rip the Band-Aid off and start having these conversations. Any other questions or comments? Oh, I lost my chat.
Becky, it looks like there's one more comment from Jenna.
Oh, from Jenna. Yes. My screen changed there for a second. Children should implement routine screening to our oncology. Yes. That's a very good point. And actually, you know what, Jenna, I have not been involved in working on the review looking at sexual function in younger patients in children and adolescents, but I know that the working group that I worked with that Ben had mentioned at the beginning, we had sort of a more adult focused and dividing it into male and female late effects and sexual function. They're also working to write a systematic review for younger populations as well. So like I said, that's currently in the works, but I'm sure that they will find some helpful research and resources that you can also utilize as well too, once that is completed and published. Okay, well, if anyone has any other questions or is interested in talking more or is interested in any additional resources, feel free to reach out to me or shoot me an email. I'm happy to talk about this stuff. It's definitely an area that we don't talk enough about. Thanks for coming, everybody.